Hi, I'm Sarah Watkins, and I am an assistant professor of emergency medicine at Texas Tech University Health Sciences Center, El Paso, and I'm also the medical director of the West Texas Regional Poison Center here in El Paso, Texas.
And my name is Scott Crawford. I'm an associate professor with the Department of Emergency Medicine at Texas Tech University Health Sciences Center, El Paso.
And today we will be talking about medically relevant arthropods.
Part of the discussion for this talk will focus on pediatric considerations for some of these presentations, and that's because a portion of this talk is supported through a grant to provide education and counseling through the Pediatric Environmental Health Specialty Unit, known as a PESU. This grant is provided through the American Academy of Pediatrics and the Agency for Toxic Substances and Disease Registry.
All right, so the findings and conclusions in this presentation have not been formally disseminated by the ATSDR, and so you should not construe them to represent an agency determination or policy. Here are our objectives. Today we will identify many common arthropods that affect humans, and we will describe methods to decrease the risk of disease transmission, as well as describe specific treatment considerations and counseling recommendations. So first off, what is an arthropod? An arthropod is an invertebrate animal identifiable by its chitinous exoskeleton and multiple jointed appendages. This is regarded as the largest phylum of the animal kingdom, and there are multiple subphyla, including Chelicerata, Tracheata, and others. Today we'll primarily discuss the subphyla containing spiders, scorpions, and ticks, and arachnids like those, and then also we'll talk about insects and myriapods. So first off, we'll talk about arachnids, and this can include scorpions. Even though the arachnid class is most known for spiders, we also see other arthropods in this class, including scorpions, ticks. Here's a picture of a tick. And mites that can cause scabies. And then, of course, here's our friend the tarantula, classic spider example. Then we'll move on and discuss insects. The class Insecta contains a lot of relevant species, including mosquitoes, bedbugs, lice, bees, and ants. We'll also give an honorable mention to the myriapods. So this would be bugs like millipedes, as you see in the picture, and then centipedes as well. And particularly, we'll talk about the giant desert centipede.
While all of these groups are arthropods and have some medical relevance, one of the largest areas of medical relevance comes not from the creature itself, but from the diseases they may transmit. These are known by the term arboviruses, or arthropod-borne viruses, stemming from the fact that they are transmitted by arthropods, usually through a bite. Mosquitoes are one of the most implicated in this disease class. While many believe these diseases are only a risk to travelers, many are also present in the United States. Some specific examples are West Nile, Zika, and dengue. While cases of chikungunya have also been diagnosed in the U.S., however, no transmission outside of travelers was identified between 2018 and 2020. West Nile transmission is from birds to mosquitoes that can then transmit the infection onto humans. The disease can also be fatal to birds. There were 2,544 cases present in 2018 and 137 deaths. The disease is often nonspecific with flu-like symptoms, but can have a neurologic disease process with a meningitis-like presentation in some. Zika virus infection is not new and was first identified in 1947. It is transmitted by the Aedes mosquito, but the presence of the infection can only be confirmed through laboratory tests on blood or other body fluids from a patient, such as urine, saliva, or semen. The disease is often mild but can cause a Guillain-Barré-like illness. There is still no current vaccine or therapy for Zika. Although local transmission of Zika was reported in the 2016 and 2017 years in Texas and Florida, there have not been any reports of local transmission since 2018, according to the CDC. Prior to this, however, there were a reported 2,490 pregnancy-related cases in the United States between 2015 and 2018. From these cases, there were 116 children born with the classic birth defects associated, and 9 infants died with known Zika-related defects. Since Zika can be transmitted by semen and sexual contact, condoms are recommended to help decrease secondary person-to-person transmission. This is a specific medically relevant concern, as the primary health effect for humans and health problems is on the developing fetus, causing microcephaly when pregnant mothers are affected. When evaluating patients with flu-like illness, be sure to collect a travel history with a specific focus on the 14 days prior to when their reported illness began. Chikungunya has recently emerged as a concern in those returning from the Caribbean and Central America. Chikungunya and dengue are both acute febrile illnesses characterized by fever, myalgia, and lethargy, and may be difficult to diagnose by symptoms alone. Dengue infections may be one of 3 subtypes. Dengue without warning signs is defined as fever plus 2 of the following: nausea, vomiting, rash, aches and pains, leukopenia, or what is termed a positive tourniquet test. And we'll discuss a tourniquet test in just a moment. Dengue with warning signs is the same as the previous list, plus any of abdominal pain or tenderness, persistent vomiting, clinical fluid accumulation such as ascites or a pleural effusion, mucosal bleeding, lethargy, restlessness, or liver enlargement. Some other laboratory warning signs may be an increase in the hematocrit along with a decrease in a platelet count. Severe dengue fever and has a particularly poor prognosis with as high as a 10% fatality rate if not medically managed. In order to check for a positive tourniquet test, a blood pressure cuff should be applied and inflated to the midpoint between the systolic and diastolic pressure for 5 total minutes. The test is considered positive if there are more than 10 to 20 petechiae per square inch distal to that location. Treatment for dengue is still primarily supportive and includes hydration, monitoring for hemorrhagic transformation, and avoidance of NSAIDs. Instead, the use of acetaminophen is recommended, particularly because of the known platelet effects. Chikungunya is noted for high fevers and polyarthralgia. Fortunately, treatment is symptomatic. The treatment is NSAIDs, corticosteroids, and patients may actually benefit from physiotherapy because of the primarily articular involvement of the disease process. Malaria can be from multiple species of parasitic Plasmodium infection and is endemic to Africa, South America, and Southern Asia. Symptoms may be present between 7 and 18 days after becoming infected, but in rare cases the symptoms may not appear for up to a year or longer in some reported cases. The symptoms for malaria are similar to other mosquito-borne diseases and include a high temperature of 38 degrees Celsius or above, along with rigors, headaches, muscle pains, diarrhea, and vomiting. The malaria life cycle is well documented, but a detailed analysis of it is outside of the scope of this particular lecture. The Aedes mosquito is known to be the vector for yellow fever, dengue, chikungunya, as well as Zika. It can live and exist indoors and outdoors, and although it is killed by frost, climatic changes recently may be allowing geographic expansion to areas that didn't previously have this particular mosquito species. The Anopheles mosquito are the primary vector for malaria, both the falciparum and ovale types. In order to protect from these diseases, some vaccines are available, specifically for dengue, yellow fever, Japanese encephalitis, and malaria, although the latter, malaria vaccine, still has very low efficacy. There are currently no therapies for chikungunya, Zika, or West Nile. For these other diseases, the use of repellents such as DEET may help. Please be sure to look for EPA labeling and approval on any planned repellents. Chemoprophylaxis is an option for malaria, but regional resistance has been a large problem throughout the world. It's best to avoid areas with outbreaks and not rely on treatment if possible. It's also good to consider the timing of your activities and adjust your activities based on the timing to try and help decrease disease transmission. For example, the Anopheles mosquito is most active in the evening hours, so avoiding activity during this time can help to decrease malaria risk. The Aedes mosquito, on the other hand, is most active during the day, and planning can help prevent dengue and chikungunya transmission by staying indoors during this period. Mosquitoes are not the only problematic arthropod for bites. Grass and woodland areas may contain ticks or chiggers that can affect hikers or even more casual picnickers. Ticks can transmit Lyme disease and Rocky Mountain spotted fever, both of which are fortunately able to be treated with doxycycline. Chiggers can create an irritating and painful rash. If patients present with this skin irritation, it can be treated with steroid creams, antihistamines, and analgesics. This particular rash is also very common in areas of tight-fitting or constrictive clothing right around the underwear line or at the location where socks are present just above the shoe. When hiking, be sure to wear long pants. Tuck your shirt in and apply permethrin to gear if you're going to an area with a particularly high concern for these arthropod species. After returning from an outing in an endemic area, it's best to do a tick check and to shower within a couple of hours to help remove any small creatures that may have been transported back with you. These steps can help to decrease tick bites and therefore limits the transmission of the diseases such as Lyme and Rocky Mountain spotted fever. Avoid sitting in long, unkempt grasses, as these are common areas for both chiggers and ticks to appear. You can see that the group of individuals on the right is far less prepared for an outing in a mosquito or tick-infested area than are the individuals with appropriate gear on the left. So if you are traveling to mosquito-endemic areas, consider the use of bed nets. If the net is not long enough to reach all the way to the floor, it's recommended to tuck it into the mattress and to pre-treat it with permethrin. Permethrin treatments to cloth and netting like this can actually last months if they're not laundered. And as a reminder, don't put permethrin directly onto your skin. It's not meant to protect in this manner. Repellents are another way to help decrease exposure, and they can be applied directly to the skin, although pyrethroids such as metofluthrin and alethrin can also be considered as area repellents. They have not been reviewed to specifically decrease disease. So the most commonly used repellent is DEET, but alternatives such as picaridin, sold under the name Cutter Advanced, and oil of lemon eucalyptus, sold under the name of Off Botanicals, are also available and have been shown to have some effect. A minimum 10% concentration of DEET is recommended, and there appears to be no additional benefit with DEET concentrations greater than 50%, so somewhere in this range is probably sufficient. The CDC does recommend a DEET concentration of 20% or greater to be able to provide appropriate repellent effects. A 2015 study looking at effectiveness of different repellents found that DEET-containing products, as well as lemon of eucalyptus, to be the most effective at deterring the Aedes mosquito initially and again at 4 hours. Some specific DEET precautions are to limit its application to exposed areas of skin. These are the only locations where you'd need it, and to only place it on intact skin to prevent any contamination of wounds that may be present. You also want to make sure that you wash your hands after use to avoid incidental ingestion of these products. Use of DEET is considered safe after the age of 2 months, but prior to this age, use of barrier netting alone is recommended, as these children would already be likely in a contained or confined space that could be easily coated with netting. So frequently patients may be brought in with a concern of insect bites, and oftentimes these are attributed to bed bugs, but it may be difficult to determine if this is the case without seeing the actual creature. Bedbugs are, in general, larger and darker in color than lice, with the adults measuring 5 to 7 millimeters in length. If a patient is coming in with bugs on them, it is probably lice and not bedbugs that they are referring to, as bedbugs actually prefer to hide during the day and avoid light. It is possible to transmit bedbugs via eggs that could be brought in with a patient, but to see the bug itself would be uncommon. Bedbugs tend to hide and come out only to feed at night, so if you're traveling or in an area with concern for bedbugs, it's best to inspect the sleeping location, including the mattresses or seams of the mattress, headboards, baseboards nearby, to look for the potential of these pests. It is also recommended to seek alternative lodging if you do have an area that seems to have these, and to keep suitcases closed and off the floor to prevent transmission of eggs. So human-assisted transportation is the primary concern for dispersal. Despite many studies to identify possible vector transmission by bedbugs, fortunately, including HIV and hepatitis B, there has been no transmission risk specifically established. Patients may have a cutaneous reaction, urticaria, itching to these bites, but the onset can be delayed by hours to days, making the exact etiology difficult to identify. Symptomatic treatment for bites with antihistamines and topical or systemic steroids have been used, but there's no specific treatment that has been recommended. So as mentioned, as bedbugs don't actually live on the human, eradication is directed to adjacent areas and mattresses and not to the patient themselves. So eradication practices include treating potentially exposed items such as mattresses or bedding in a hot dryer for at least 30 minutes to kill off the eggs and the nymphs, and also to clean and scrub the seams and folds of a mattress with detergent and to seal any cracks in nearby woodwork or headboards where bugs can hide. Lice have several subspecies and determine the likely location of infection. So this includes things like Pediculosis capitis, or head lice, or Pediculosis humanus, which are body lice. They are translucent and small, usually much smaller than mature bedbugs. Lice must eat every 2 days in order to survive, while mature bedbugs can actually survive for up to 6 months without a meal. The primary treatment, therefore, for lice or patients with a lice infestation is improved hygiene, and here the use of permethrin cream can be effective because the lice are usually obligate parasites on the patient themselves. In addition to showering, special fine-tooth combs can be used to remove the nits or the lice eggs from hair or other body surfaces. If body lice are identified, the permethrin cream may be used. Patients should be instructed to bathe in shampoo, drying completely before they actually apply the permethrin cream. They should then apply a thin coat of the permethrin cream to their entire body and leave it in place for 10 minutes. After that 10 minutes, it should be rinsed off with just plain water. It actually may be appropriate for the emergency department to assist with this procedure, especially in our homeless population, because of the difficulty with finding bathing facilities for these individuals, and leaving the permethrin cream on longer can actually have some mild toxic effects. So while lice have been implicated as a vector for some diseases, including typhus, local skin irritation and itching are usually the primary concern. Despite the overall benign effects of lice infestation, severe infestations have been identified, and chronic infestations have even been implicated as the etiology for anemia in some case reports. The image on the screen is actually the hair and scalp of a patient who was brought in from a homeless shelter after being found down. The cardiac rhythm initially identified was pulseless electrical activity, and during an arterial line placement to monitor effectiveness of resuscitation, the blood coming out was noted to be particularly watery, and an emergent transfusion was performed just based on this appearance. The hemoglobin did finally return back at 2.2 grams per deciliter. With the emergent transfusion, pulses were returned, and the patient was able to be admitted to the hospital for management but unfortunately expired on hospital day 2. So despite a search for alternative sources of blood loss, including the GI tract, there was no other identification for where hemorrhage could have occurred. Prior record review indicated that the patient had a known lice infestation 1 year prior. This is possibly the first case report of anemia caused by lice. In severe infestations, please consider evaluation of hemoglobin. A second news story with a similar presentation was actually reported in a young girl in Georgia just this month. Another presentation for patients with insects on or in their body is actually the presence of these creatures in an orifice, specifically the ear. The most common such insect is the cockroach, as identified in the journal article in the Laryngoscope by Antonelli in 2001. Although ticks, bees, and beetles have been described as well, the approach for extraction will depend on the size, location, and the cooperation of the patient. But one of the most important things to do is to first kill the insect to minimize discomfort, because as long as the patient can still feel it moving, they will not be able to relax to allow you to perform an extraction. Ethanol and isopropyl alcohol were the most effective in killing cockroaches, but both microscope oil and lidocaine have also been shown to work relatively quickly in experimental testing. All of these substances will kill a cockroach within approximately 90 seconds. If a perforated tympanic membrane is identified or suspected, however, these substances should be avoided. Alligator forceps are a good option for removal of ear foreign bodies because they only articulate at the fulcrum at the far end of the instrument. Ear curettes have also been used to help with scooping or scraping, but caution should be applied to prevent breaking the insect into multiple pieces unless this is the only way to remove it. One other technique that is used for extraction is a specialty suction device. This particular item, called the Hognose suction, can be attached to the end of an otoscope, and a piece of suction tubing, as seen in the central image, can be applied. Once visualization of the insect is obtained through the otoscope, an opening in the suction system can be occluded, and the foreign object will be pulled out using the attached suction device. You can see the insect here in the right image was actually able to be pulled through the Hognose suction out of the patient's ear.
And the next creature we'll be talking about is the maggot. So maggot infestation is called myiasis, and this is defined as an invasion of organs and tissues of human beings or other vertebrates by fly larvae. When such infestations occur secondarily on wounds, it is termed facultative or traumatic myiasis. Although this can be disturbing to both patients and healthcare providers, these superficial infestations occur when necrotic tissue is present to attract the flies. The flies lay eggs, possibly on the bandages, and the larvae can crawl through this to the underlying wound. The larvae, though, only actually feed on the necrotic tissue, so back in World War II, they were actually used to help with wound cleansing. Today, with advancements in antibiotics, we should really just be removing the larvae to help allow tissue healing. There is a higher risk for myiasis development in warm climates and also in the indigent population. Some techniques to remove the maggots include irrigation, mechanical extraction, and some have actually described techniques involving chloroform or ether to help draw the larvae to the surface. You should definitely consider local anesthetics for patient comfort during procedures where you have to remove maggots, and sometimes you might have to do multiple procedures, for example, if there's a sinus tract formation that can allow some larvae to hide. Now we'll move on to scabies. Scabies is a disease caused by the mite Sarcoptes scabii, and this causes irritation and rash as the mite burrows under the skin. This can actually take 4 to 8 weeks to appear, and during this time, transmission to other hosts is possible. This is most commonly described in the web spaces of the hand, but scabies can occur in other locations on the body. In adults, it can also be transmitted to sexual partners. And if you suspect scabies, the treatment is with permethrin 5% topical cream, similar to the treatment for body lice. If this proves ineffective, then you can consider the use of malathion 0.5%. When treating infants and young children, scabicide lotion or cream should also be applied to their entire head and neck because scabies can affect the face, scalp, and neck as well as the rest of the body. Now we'll move on to the Hymenoptera. This includes bees and ants. One of the most common and serious health effects to humans from arthropods after mosquito-borne disease is from Hymenoptera. And this is because of the high rate of anaphylaxis to the envenomation. According to the CDC, over 1,100 people have been killed since 2000 in the United States from hornet, wasp, and bee stings, with an 80% male predominance. The Hymenoptera species are called that because they are composed of colonies that are mostly made up of females of the species, and the stinger is actually a modified ovipositor. So only the females actually will have stingers because they are the only ones who deposit eggs. Just an honorable mention for Africanized honeybees. These are the family Apidae, just like all honeybees. And these started to be more prevalent in the United States after the 1950s. So Africanized honeybees were actually genetically bred in Brazil to attempt to increase honey production. But several swarms escaped from the laboratory and began to interbreed with native bee species. They have been migrating northward ever since, and hives were found in Texas by 1990. The Africanized honeybees are known to be more defensive, and they attack very aggressively in large swarms. Here's a picture of a patient with multiple bee stings with stingers still in place. You can see on her face there are at least about 8 stingers there. And then on the right-hand side is one of the bees that was still found crawling around. On the left-hand side is her back. So this is an example of a massive bee envenomation of a husband and a wife that were near a bee colony when it was sprayed with water, and the bees then attacked both of them. Luckily, they did well despite the large number of stings, which can actually have direct toxic effects to tissues such as the myocardium. Hundreds of stingers were removed from these patients, and actually transport was delayed because of safety concerns for the first responders. Live bees were found in their hair, and they even posed a small hazard to the ED personnel, as you can see by that bee that's on the counter in the ED there. Many textbooks describe the importance of flicking the stingers out with a flat object like a credit card or, scraping them off, as opposed to pulling them out with tweezers or forceps because of the supposed risk of squeezing out any remaining venom from the attached venom sac into the body. And so this is really more of a theoretical concern. But based on animal models, most venom has actually been injected within 40 seconds. And so really the risk of squeezing out further venom into the patient by plucking the stinger out, you really shouldn't have to worry too much about that. Really the important thing is to get the stinger out. And so any method that you need to do to remove the stingers, including forceps, should be seen as acceptable. You don't worry too much about flicking them out. And certainly in certain places in the body, you actually can't flick them out. Like, can you imagine flicking them out of the eyelid or the ear canal or anything like that? So here's another picture. This is after the patient was transferred from the EMS stretcher to the ED bed, and you can just see many, many stingers remaining on the sheet there. Here's a picture that you might have seen in the press lately. This is a picture of the Asian giant hornet. And while likely not a major player in the U.S. health scene, Asian giant hornets got a lot of press early this year, 2020, after being found in Washington state for the first time. They are native to Japan, and they're the largest of the hornet species, and they have a very powerful stinger and venom, as you can imagine. The impact, however, to the United States, the fear is more for interaction with native honeybee populations rather than humans. We don't want these giant hornets to kill off our native bee populations that are so necessary, critical for pollination. And while these vespids are potentially lethal, they are reported to kill at most a few dozen people per year globally, but some experts say it's probably fewer. No murder hornet deaths have been reported in the United States, however. But overall, in the United States, Hymenoptera, well, specifically hornet wasp and bee stings, kill on average 62 people per year. Another hymenopteran is the ant, and this is a picture of the fire ant, which is common in the southern United States, including Texas. They are native to South America, and they were imported and first noted in the 1930s in Alabama. They form mounds near the colony and can be very aggressive when threatened. Many of you have probably already seen them around. Despite the prominent mandible, the clinical effects are actually not from the bite, but from the sting. So they do have a stinger at the base of the abdomen through which they inject venom. Usually the ant starts out by biting, and it gets a grip with its mandibles and uses that leverage to aim its stinger. It often will sting repeatedly, maybe 7 to 8 times, in a circular pattern around the bite site. Allergy and anaphylaxis are possible, but are uncommon. People who are allergic to bee stings, however, may have a higher likelihood of a cross reaction and also be allergic to ant stings. Here's a picture of a patient who was envenomated by the fire ant. Following a sting, the venom may produce urticaria and inflammation, as you can see in this video. And actually, if you look closely, you will see the pulsation of blood to the inflamed wheal at the base of the 5th digit. Pustules or bullae formation are also possible, as seen on the 3rd toe, but thanks to the antimicrobial nature of the venom, the pustules are usually sterile and should not be popped. For management, wash the area with soap and water and apply a cool compress. Standard non-prescription pain relievers can be taken for symptom control. Now we're going to move on to spiders. And here is a picture of the thing that all of our patients are scared about, right? This is the deadly MRSA spider. Just kidding. We're not going to be talking about the MRSA spider today. Not a thing. We will talk about brown recluses and black widows. So starting off with the brown recluse, Loxosceles reclusa. These guys are found mostly in the southeastern U.S., but we do have subspecies or various different species of Loxosceles in Texas. The brown recluse, as you can tell by its name, it's a recluse. It's shy. It doesn't seek out humans, and bites are actually pretty rare. Now, the bites usually happen when their habitat is disturbed by us. And the toxins can produce varying degrees of symptoms. Many patients don't notice that they've been bitten. They might have some mild irritation, and then all the way up to the big concern, which is the rare ulcerative skin lesion. Now, children might actually be prone to something dangerous, which is called systemic loxoscelism. And this is children usually less than 10 years old or so within the first couple of days after a brown recluse bite. And unfortunately, this can actually cause disseminated intravascular coagulation and renal failure due to rhabdomyolysis. Treatment is largely supportive. Antivenom does exist in some countries, but not in the United States. Its efficacy in United States spiders is unclear. We have different species here. Some studies have looked into administering dapsone to brown recluse victims. However, this is not routinely recommended. The evidence is not good. And then dapsone, of course, has the risk of causing methemoglobinemia in our G6PD deficient patients. Generally, for most of these patients, careful monitoring and consultation with a poison control center is recommended, and certainly if the patient has systemic loxoscelism, then I would highly recommend you call the poison center. Now we'll discuss the widow spiders. So in the United States, we mostly have black widow spiders, but we have brown widows as well. These are the Latrodectus genus, and they have this very classic, recognizable bulbous abdomen and then a bright red hourglass on the ventral side. This is the Latrodectus Mactans. They often hang upside down in their web, and the web is very irregular looking. It's not the beautiful regular web of an orb weaver, for example. The black widow web is irregular, it's very dense, it's messy. You can easily see the hourglass on the female black widow, which is the medically relevant sex of black widow. And actually, we have 5 species in the United States. Most of them look pretty similar, but as I mentioned, there is a brown widow spider as well, Latrodectus geometricus, which has a body similar in shape and a ventral red marking, but it is more of a brown or tan color, and it has some yellow and cream-colored streaks along it as well. Here's a picture of that. But actually, you know what, this could also be an immature western black widow spider too, so they can look pretty similar. Black widows have a very large range. They live pretty much everywhere humans live. For example, this photo was taken of a spider under the coffee table of a colleague while we were having a journal club. Brown widows are still less pervasive than black widows, but the range is possible across much of the southern U.S., although they were originally only found in Florida. So a study by Dart in the Annals of Emergency Medicine in 2019 reported over 1,300 calls about black widow bites were made to poison control centers back in 2016. And the characteristic envenomation syndrome with this neurotoxin causes latrodectism. So the characteristic envenomation syndrome with a neurotoxin specific to Latrodectus species causes latrodectism. And this syndrome consists of severe pain, muscle cramping, which can even be diffuse throughout the body, remote from the bite site. Severe abdominal pain has been described. This can even mimic a surgical abdomen, and back pain as well. Really, truly diffuse pain all over. The pain can be so horrible that it may actually mimic a myocardial infarction or even appendicitis. And patients are classically very hypertensive, tachycardic. They often will have a very localized bit of diaphoresis just at the bite site, which you may be able to feel if you slowly drag your gloved finger over that bite site. If you feel a little increased friction there, then you should be suspicious of a black widow spider bite. There's also something called Latrodectus facies, which is where the face of the patient, especially more commonly in children, you can have some infraorbital edema appear. There is an antivenom available, but it is rarely used because of the high risk of hypersensitivity reaction. Patients don't die of black widow envenomation, but there have been deaths reported secondary to anaphylaxis from the full IgG antivenom product. There is a newer Fab 2 fragment version that is not quite on the market yet, but there was a trial on 60 patients in 2019 with this newer Fab 2 antivenom. It did show improvement in treatment relative to placebo, 77% improvement versus 51% improvement with placebo. And this new Fab 2 version is expected to have much fewer hypersensitivity reactions because it is not the full IgG immunoglobulin. It is just the fragment, not including the FC portion, which is typically the most allergenic portion. The mainstay of treatment for black widow envenomation at this point is truly the early and aggressive use of analgesics, including opioids. This is not a time when you want to withhold opioids from your patients. They're in severe pain. They may also need concomitant benzodiazepines, and they very well may need admission for pain control. Quickly, we'll go over myriapods. We do have the Scolopendra polymorpha, the giant desert centipede here in Texas. Myriapods includes millipedes and centipedes. Millipedes aren't particularly medically significant. Millipedes and centipedes are very important for ecological breakdown of decaying material. And the centipedes, however, are medically relevant, and they do have venom and can envenomate humans. And there are at least 61 types of proteins and peptides that have been identified in Scolopendra venom. And some envenomations cause only a small focus of skin necrosis and local pain lasting from hours to weeks. There was a single case report of envenomation from the giant desert centipede, which describes severe muscle breakdown resulting in rhabdomyolysis and renal failure, but this is rare. The centipede envenomations I have seen have presented in some ways similar visually to those of a rattlesnake envenomation or a copperhead envenomation, where you can get actually marked edema and even some erythema of the extremity, but they should not cause much in the way of laboratory abnormalities. And this resolves just with supportive care. So there have been a few case reports suggesting that centipede envenomation was the cause of death in patients. However, some studies actually suggest that perhaps this is due to anaphylaxis to the centipede venom, in which patients who are already allergic to bee stings might have an increased susceptibility. So this may have actually been anaphylaxis causing the death rather than a true venom effect itself. So now we will talk about scorpions. So in the southwestern United States, there's one medically relevant scorpion, and this is the Arizona bark scorpion, Centroides sculpturatus, which used to be called Centroides exilicata. This scorpion has a neurotoxin, and in Arizona, it causes about 200 envenomations annually. Here in Texas and throughout the Rio Grande Valley, we have the cousin, the striped bark scorpion, Centroides vittatus. Visually, they are very similar, pretty much indistinguishable, but they do not have neurotoxic venom. Now, before, in prior years, we could say, oh, we're in Texas, we don't have to worry about the Arizona bark scorpion, that's only in Arizona. But actually, in 2018 in El Paso, there was a report of neurotoxic symptoms from a scorpion envenomation, and that suggested that the Arizona bark scorpion may be expanding its range. The theory is that the bark scorpions hitch a ride on landscaping vehicles. They like to live at the base of palm trees, and so if you're importing palm trees for your yard, then you might be importing some bark scorpions as well. Now, these scorpions do have neurotoxic venom, as I mentioned, and they can cause particularly toxic effects, especially for small children, usually less than age 6 or so. Pets are actually at risk as well, and the effects look a lot like a combination of sympathomimetic and cholinergic toxidrome. So we worry about hypertension, tachycardia. These patients can have marked nystagmus, which we call opsoclonus, inability to control their eye movements. They have inability to control their arm and leg. Just all of their muscle movements are affected. They're often very agitated and crying. And then the thing we really worry about is actually hypersalivation and development of pulmonary edema. In the past, these patients would often have to be intubated and spend the night in the PICU, but now we have antivenom. And for the patients who have neurotoxic effects, and especially if they have hypersalivation, increased airway secretions, then that would be an indication to give the antivenom. And the antivenom really is amazing. You go from a patient who you think you're going to have to intubate to a patient who within a half hour or so is completely cured. You watch them for a few hours in the ED, you discharge them home. So it could be as little as a 3 to 4 hour ED stay in total. For patients who are adults, they usually don't have concerning neurotoxic effects. They usually would have paresthesias, and these go away over a few weeks. And the treatment for them is largely symptomatic with NSAIDs. Some people do antihistamines, but there might not be a whole lot of benefit for that, just symptomatic supportive care. Now we'll talk about the Reduvid bug. This is sometimes also called the kissing bug because it has a propensity to suck the blood of humans and other mammals, particularly at night. This name actually is given to over 10 species of insects, and these insects are known as triatomines. There's geographic overlap between the species, especially in the southern U.S., including Arizona, New Mexico, Texas, and Florida. And they do extend into Mexico and South America as well. Triatomine bugs, these reduviids, are the vector for transmission of Chagas disease, which is caused by Trypanosoma cruzi and causes multi-organ dysfunction. Here's another picture of the Reduvid bug. Misidentification is pretty common. But even if you are bitten by a Reduvid bug in the United States, the risk of Chagas transmission is fairly low. Even so, the CDC recommends capturing the bugs in a jar or a bag, or kill them by putting them in a freezer. You could put them in rubbing alcohol. Basically, don't squish them because that will make them harder to identify, and also that can increase the risk of transmission because you're contacting the bug's bodily fluid. Even so, transmission of the Trypanosoma cruzi parasite is difficult because it is not spread from the bite itself. The parasite is present in the feces of the Reduvid bug and requires that infected material be rubbed into a wound or exposed to the mucous membranes. The CDC reports as many as 300,000 people in the U.S. may have Chagas disease, but many may not know it. Here is a picture of unilateral eye swelling, which is known as Romagn's sign. This may be present in the early acute phase, and then after that, many individuals may be asymptomatic for decades, but some can develop cardiac complications, including myocarditis, or they may have GI symptoms such as esophageal or colonic dilatation. Treatment is with antiparasitic medications such as benznidazole, which is approved for use in children 2 to 12 years of age.
To close out our discussion on medically relevant arthropods, I want to share a news story from back when news didn't always contain the word COVID, describing a news report from National Public Radio in February of 2019 that described a group of researchers in Terni, Italy, that began working to test whether they had successfully been able to genetically modify mosquitoes using something termed gene drive modification to be able to breed hermaphroditic offspring that would be sterile and thus work to further decrease the population of mosquitoes if they were to be released. Now, this may actually prove to be a useful method for decreasing mosquito populations and therefore some of the arthropod-borne diseases such as malaria and dengue that they cause, but we still have yet to see whether this is a safe or effective method for performing this. And many of us may be skeptical with the previous such modifications that we saw in the Africanized honeybees that were released in the 1950s in Brazil, but just something to keep your eye out for as we're looking for solutions to decrease the medical impact from some of these diseases. We hope that you found the discussion here entertaining. Please feel free to reach out to either one of us if you have questions using the email addresses shown on the screen. If you have any questions about pediatric environmental health, please feel free to contact the Southwest Center for Pediatric Environmental Health at the number shown on the screen. We're available 24/7 for free consultation and advice related to pediatric and environmental health issues.